for the next interop workshop. It is a big deal for those of you who have seen what we do here all the time. Many times it's just interactive between the group that is here and we cover topics. Every now and then we'll have a guest. We have a very special guest coming up in next month, and it is Liz Lewis, who is the Director of Product for Commonwealth. And any of you who have investigated the Commonwealth network know there's a lot going on with all of the QHENs, and there's a lot of benefits to all of them. We've worked with Liz and the Commonwealth folks quite a bit here. They have some very unique characteristics to their particular solution, and also Liz is Liz is a heavy hitter in the space. Let me just put it that way. Overall, I won't take a bunch of time giving you her bio, but she graciously agreed to be put in the hot seat with Ron and myself for next month. And we're looking forward to that. It will be, mark your calendars, and Jessica will give you an invite in the Slack room, or excuse me, in the chat as well. But it's August 27th. That is a Wednesday, basically a month from now. But Wednesday, August 27th at 2 Eastern, 1 o'clock Central, same time as we're doing right here with this, 11 o'clock Pacific. If you are doing anything in the interoperability space, and if you are here, you don't want to miss this one. This one's going to be good. We've already had some meetings with her covering the topics that are there. There's a lot of good stuff there. So please mark your calendars for that. In addition, I want to tell you that there is a lot in the news, and I don't normally cover the news per se, but there are a couple of things that are certainly noteworthy if you haven't already seen them. There is a meeting going on in Washington, D.C., literally as I'm speaking here right now, today. And we have some peeps that are actually in that meeting. So while we don't have any inside information yet, I expect to hear before close of business today, and we're going to be announcing out and the details that we can get on that. I've been told that things are very positive that are being expected out of that. So what we will do is take anything that we get from our folks that are actually in that meeting and produce that out. If you are inclined to get that information, do me a favor, just write info in the chat there so that we get a list of people that want it. We'll put that against the list of registrations here and include you in the distribution list on that so that you get it. So just type info in there, and that'll give Jessica a way to make sure that we're getting that. And we're not spamming you for things that you may not want, but there's a lot of good stuff going on there. We've talked a lot in the past with regard to Epic and their QHEN participation. They announced, you may have seen it, that just as of June 20th, they did 28 Epic facilities moving to their QHEN in June alone. 28, basically more than one a day, business day that is. They're careening towards their QHEN participation. Of course, they are a QHEN there as well. They're slated to be trying to be done with that by the end of the year. And while I don't have any inside information on that, all indications are they're going to succeed in doing that, or they're going to come close. There's a lot going there. Also, I do want to give everybody a quick update on OIE, which is the open source group of engineers predominantly that are taking over, that have picked up the open source MirthConnect and have already started to develop on that and enhance it and pick that up, because they're all very dedicated people in terms of ensuring that all of those use cases for the former MirthConnect open source are going to be maintained. Both Ron and I talk with them regularly over there. Some of them used to work for us, as a matter of fact, so we know the team there very well. They have released their version formally of version 4.5.2. Zen has taken that. We have completed our testing of it, our security scanning, and the porting of our internal tools that we have built into our versions of of that, and we will be migrating to it starting here right away. We're excited about that, and we do support the efforts that they've got there. I think it is good, and we continue to work with them. I mentioned a poll earlier. I do want to do that now. If you would give me a show of hands, or put open. Just type open in the chat, if you will. How many of you use an open source tool in your HIT efforts? I'm really curious how many people do that. Okay, 3, 4. That's good. Okay, open source overall. How many of you use an open source integration engine? Type. We'll set that different. We'll make IE integration engine on that. How many of you use the open source there? Okay, a handful of it as well. Not too surprising for in many cases. They'll, if you're doing a lot, if you're with an HIE or something along that line, you may be using the commercial version of MirthConnect or some other integration engine that's there. That's good. How many of you use the closed source? Type closed in there. Let's see what we got that might do the or Gemini. Yeah, there you go. That's good. Okay, so we got a number of closed source versions there as well. That's excellent. So I am curious, because we do have a lot of folks that use the open source version of MirthConnect. There are a lot of people that use the closed source that might want to use the open source version if it had all of those things in it. How many of you that are using the closed source use advanced features? And obviously, I'm talking about MirthConnect in that particular case. How many of you use the advanced features? So type advanced or AD or something like that in there. Anybody using any of those? Look at that. None, but there are an awful
I
lot
mean,
of.
this would be their SSL extensions or other elements of their product there.
Okay, and the SSL in Gemini, that's perfect, because we have something to do with that. Okay, enough of that. If you do have any other comments, please put them in the chat. We'd love to have that with regard to what we're doing here, because that helps us. We're trying to make some decisions on how to support the open source community as well. As everybody knows who has been on these before, we have a forked version of that integration engine. We've made a lot of customizations to it. We use it internally, but we also look at making the advanced things that we use available to others as well, like we did with SSL extension, because we want to support the community overall. So if you have any other input on that, and you'd like to encourage us, or have any idea of something else that we should build that will help you, it's a good opportunity to put that out there, because we'll certainly look at doing that. All right, sorry for all the housekeeping there, but there's a lot going on in this marketplace. We'll start getting down to the nuts and bolts of what we're doing here. As Ron and I prepared for this particular meeting, what we really we started talking about is what Ron runs into all the time in talking with prospective clients and existing clients. And what ended up coming out of that was actually some more details on recurring themes that we've actually covered in some of the previous meetings, but they're worthwhile to talk about as well. I'm going to shut up because I'm sure everybody's tired of hearing me. But the first topic that we ended up diving into was the use of APIs, whether FHIR or not, and how people make decisions to use them. So, Ron, you had a lot of thoughts about the use of APIs and where they're really good and what you got to be careful about. And so I'm going to throw you the microphone for a few minutes and have you drill into use of APIs for a second and what to watch out for.
Certainly, Jim. One last piece of housekeeping. I see a Michigander on this call that is not identified with a name, and I just want to give you props for being from my home state. Thank you very much. Whether you're still there or not, you're still sporting the 248 area code. So, welcome to the show.
Fantastic.
Thank you.
So APIs, we have so many young companies that are out here bringing, innovation to the marketplace. And they have very, very smart employees, great ideas, insanely interesting products, and they're all working with what they know about healthcare interoperability. And many of them, what they know is what they read on a particular EMR vendor's website, and they don't have a lot of, tried and true experience, feet on the, feet on the ground kind of scenario. And recently, we've been talking to quite a few folks that have actually invested lots of hours, 200 hours in one particular conversation, getting connected to the Epic FHIR API solution, and found out as they were progressing through that project that one of their use cases was to return and present results from activities from their application back to Epic. And they went, oh, we can't update any results relative to traditional types of result data, like clinical testing, the blood pressure, these kinds of things. It's limited to lines, drains, and in a very, very finite group of things that you can actually do a post against the FHIR API. And so up until that point, they were all good in some ways until I started to ask them some very specific questions, right? Are you taking updates to demographic information with the patient through your application? Oh, yeah, we are. Okay, are you able to push that back into the FHIR API, the FHIR API? Oh, no, that's read only too for us. And so the way that the folks are venturing into this is like, oh, we can get access to all that data, and the initial scope or concept is it works, but then they find out that, wait a minute, we gapped. We didn't realize we need to do X, we needed to do Y, and then they're kind of in a dead end. And and then the second part of that process goes, we've got Epic handled, but we now need to do Meditech
Oh,
or
yeah.
Greenway or Cerner. And they start to look at that integration, and okay, it's FHIR, but it's now a little different. And there's no common access to these solutions. So now you got a credential management problem statement. So for every EMR, every potential client instance, you got to manage the credentialing now, which creates a whole secrets management problem statement. And most companies aren't really constructed to do that with dynamic tools in an appropriate manner so they don't expire and all sorts of things. Um, as we were kind of walking through the situation, they had done a POC with one particular Epic facility. It seemed to be working until they got to this gap point where they couldn't write the results back. And I had been doing some pretty serious research on it all, and found that not every Epic facility enables the same features that Epic publishes as being potentially usable. So in other words, a particular Epic facility may say, no, we're not going to expose that. So now what you had work at Epic Facility 1 is no longer available at Epic Facility 2.
And that's not relegated just to Epic.
No, it's not. It's, you got to think this is a particular health system or a particular entity that's making their own security decisions with their own security team, and you now have those barriers there. Um, and frankly, like a lot of things, knowledge and comfort level become part of the problem statement, right? We've been doing some, yeah, exactly, Darius. There are charges, there are costs. That is definitely a particular point in this discussion. Um, and one of the things you're up against is the staff of the facility, right? And Jim, close your ears. I'm gonna probably say something that's going to offend you,
Uh-oh.
but older folks tend not to embrace newer technology very well.
Shut up.
So, rather than older folks understanding the concept of JWT and TLS, they want a VPN. and we're not doing this without a VPN, yada, 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 yada.
Have you
And
noticed the color of your beard, dude? I'm just saying.
you
Okay.
got me beat by a few years, buddy. Um, so you run into those particular working issues too, right? So one of the things that I've tried to do with folks for a long time, and it goes back to my meaningful use certification, work that I did for the behavioral health EMR. The government has mandated very explicit things that thou must do to have an HIT certified product. And up until recently, FHIR, which is use case, is relegated to patient access to data, not systems to systems, not applications to applications. It was really fleshed out in the 21st Century Cures Act to say, how do we make it easy for application creators to get patients access to their data in a read-only manner? And that's what you have. So if you're a clinician or a practice or an AI technology company who's wanting much more data and is going to be augmenting that data with uh, plan of care data, more evaluation, ongoing, digestion and recommendations at a clinical level, you kind of end up in this dead end, which is really problematic.
And
Verse, go ahead, Jim.
oh, I was just going to interrupt you there for a second and go, but Ron, there are absolutely fire specs that allow you to write.
Yeah,
So
but they're
why?
not enabled. They're not enabled and they're not necessarily targeted for the use case that's there. Now, you can have uh, uh, you can have you could have a special situation where a facility might turn on a particular feature or a particular conformance methodology, post, a get or a post or a put. But that's a battle you still have to make one-on-one. It's not a rinse and repeat turnkey solution. You've got to get, into the facility. You got to start having a discussion. You got to talk to their security team. You've got to then go back to the EMR vendor and have the EMR vendor enable that for a particular client key. It's not the seamless provision your app, you get the keys to the kingdom, move on and do what you will. And so HL7 integration, as arcane as so many want to say that it is, has a very trusted exchange pattern, has a very trusted security pattern, even though we all hate VPNs in the general sense. That is a known state. It's been around since the 80s. It's been in production, hard production since the 90s. It's a mature
Right?
solution and a mature product. And the EMR vendors have the ability to manage a particular integration for the use case of that integration with HL7 messaging, meaning they're not addressing a use case to the masses, they're addressing a use case between Epic client A and vendor client B, and what do they need and why do they need it.
Right.
So it's a huge benefit. And in most cases, what we learn, although there are deviations and variations in HL7 messaging for sure, typically it's not heavy lifting, right? It's little tweaks on certain places and spots in an HL7 message. And so you can end up with a cross EMR pattern, a singleton communication methodology into your application stack as a HIT vendor, and building some normalized methods to interact, and handle those little tweaks over in your integration engine between an Athena ADT or an Epic ADT or a Cerner ADT, right? Um, so that's really something for us recently, has become fairly prominent in discussions with folks. And when I take them back to HL7 gets you across all the EMRs. It gets you to a normalized methodology of communication, and you're probably not going to get much pushback from your client or the Epic the EMR customer. Um,
So what we ended up talking about in detail, kind of summing that up a little bit, is that it is just so vital for you to define your business requirements going into it. And sometimes if you're long in the tooth like Ron is, making another old joke just because he did to me, you've been around a long time and you know where these gotchas are. And the new technology is fantastic, and we want to lever it every time that we can, but it isn't the end all be all that is there. But the thing that we see, Ron, and you mentioned this earlier, is that you really have to be honest with yourself. If you have the experience to really know what your use case is and what your future use cases are you connecting to only one EHR? Are you going to connect to multiple EHRs, different versions of them? Are you going to have to receive data, or you have to give data too? Are you feeding that back? And a whole host of other things. If you can't really define those business requirements in detail and know that you've covered everything, you should be getting somebody who is long in the tooth to help you. Now, Zen does that kind of thing, but we don't do all of it, and there are lots of others that are out there. So we encourage you to seek out and get help where you need it. Any other thoughts on
you
that?
know, Jim, in the 30 plus years I've been in this IT space, writing software, doing things. Um, I love the requirements ask, do you think we ever need to do X? And I'll say that to a principal or a founder, and they'll go, no, we never have to do that. We'll never have to do that. And then 3 months later, they go, hey, Wilson, can we do X? No, we can't. I asked you about that 2 months ago. No, we can't. Well, that's a pretty common problem in the fire space, is where I'm going with that, right? And you've got to be cognizant of that. So your use case definition and your requirements up front, you have to be honest with yourself. Just because you think it's going to cost more to write back, it may be very expensive to do it much later when you really need to do it.
Oh my gosh, yes.
Merrily.
Yeah.
Yeah, I know that we have a number of participants from on this call from health information exchanges, and I know they've often been in the front lines of connecting to EMRs. I'm really curious to hear from some of them what your experience has been with FHIR or API connectivity with the EMRs in your community versus the traditional HL7. Are you seeing a trend? Are you seeing FHIR starting to start, becoming real where you have real world use cases? And if so, are they with your provider organizations or with they a different kind of stakeholder? So just throwing out a topic of conversation.
And Dan, you're dead here. It's good to see you, Dan. I haven't seen you in a long time.
Hey, Jim, you too. Just real quick, and I've got to excuse myself for 11:30 meeting, but I did want to respond to Marilee.
Yeah.
Not so much from the EHR vendors. In our community, which is Monterey Bay, San Francisco Bay, much of the fire activity is being driven by the payers.
Payers, yeah.
And virtually all, it's 90% or more is being driven by the payers.
Yeah. We're seeing that too, Dan. We're seeing that too.
That's the same here.
Yeah. Yeah. I kind of think on the provider side, they're going to wait for HIEs to FHIRize everything. That's kind of my anticipation. Don't know yet, but I don't think it's going to be driven by the EHR vendors. I think we've got to give it back to them from the HIEs. And Mike and others, I don't know if you feel the same way.
Well, I focus a lot on the inbound, the message ingestion to our HIE, and I haven't had to deal at all with FHIR. We've got my other teammates in the technical side, they're dealing with it with Zen's help. But all of our data contributions are coming in as CCDs. We still get HL7v2 messages. Some of our clients, their EMR vendor doesn't even support the VPN that Ron was talking about earlier. I'm actually in the process of migrating a bunch of SFTP stuff from one server to another. So from the EMR level and the practice level, I don't see like you said, the EMRs aren't driving it. I don't even see any questions where they say, "Hey, can we use it?"
Yeah,
Yeah.
yeah,
One of the big issues with it is that there's no succinct payload right now in the FHIR. Dan, nice to see you.
yeah.
Um, there's not a succinct payload like there is in HL7 or a CCDA. When you think about an HL7 message, respective to FHIR, you got a patient resource, you got an encounter resource, you got insurance information. You got to go get 6, 8 resources, not a high level object that gives you back all of those individual resources to make up the same level of data in an HL7 message, right? So there's more work to do, quote unquote, to get the equivalency of an HL7 message or an SIU on the FHIR side, right? Which really, when you start to, and this is being spoken about in all the national network data exchange technical committees. I'm on 3 of them. Everyone is pulling their hair out, trying to figure out, how do we iterate over this? Should we give a bundle back?
Right.
Should we build abstraction and call it an object? And I mean, it's on and on and on. And one of the approaches that Zen has taken, Marilee and I were talking about some of these changes that were coming in TEFCA and the direction. And I said, one of the things we got to be in a position to do is digest format A and produce format C for folks, right? Give them a transformation methodology. So many of you HIE folks are transitioning to FHIR-based CDRs from older technology, right? Are those solutions effectively consuming CCDAs to FHIR? Are they effectively generating CCDAs from FHIR? These types of things. HL7 is another one. All of our young health tech companies, I show them an HL7 message and their eyes cross and they roll back in their head. Like, what am I supposed to do with that? And so we end up with a solution that we're looking at that says we're going to take this HL7 message and turn it into a human readable JSON schema bundle effectively and give it to you. So like Katrina's saying, bulk FHIR is an element, but there are people in the FHIR community that hate bulk FHIR. They're all screaming about, we're not doing bulk FHIR. We no. So there's consensus issues, there are mechanics issues, and it's because it's so young, literally. It's so young. And I had a discussion 2 weeks ago about resource IDs and patient searching and lookup. And it took 40 minutes of the discussion from some old sins that I committed in an EMR and other EMR technology vendors committed substantially, using the primary key of a patient table as a patient MRN in an outbound HL7 message. And any of you that have been around for a while know exactly what I'm talking about. I don't have to mention any names, but when these entities started to merge together, you had a patient MRN of 10,125. And there was a 10,125 in system A, and there was a 10,125 in system B. And what did you get out of that when you were done? Was it Ron Wilson and Marilee Benson that are now Ron Benson?
Bang.
Who knows? And
Bang.
it was a mess. Similar things are happening in the FHIR space. People are using resource IDs as patient referenceable items. A resource ID is the primary key for a resource inside of FHIR. What happens when you merge, migrate, bulk load, join, merge, whether it's 2 systems merging or merging patient records? What happens? Well, the conversation was very telling. There were folks telling me I was wrong, and as we got through the use case, they went, oh, and got very quiet and are now back looking at how they're doing it, going, no, we need to use actually a mnemonic and a reference that can stay with the patient record, regardless of whether they're in the original system or a fresh new migrated system or 2 entities merging 2 systems together. The resource ID doesn't matter at that point. It can be anything. The MRN, the mnemonic reference for Ron Wilson and Marilee Benson, stays the same between the systems. And if there are collisions, you can manage those collisions in a much better detail. So these are all of the things that are going on around this FHIR space, which I've been saying. I was a proponent of FHIR when I first met Jim and Marilee 9 years ago. I had this crazy idea about using Happy FHIR to build a provider safety net for their own data from their EMR. So basically, EMR does an integration, takes data from their ECW instance and pumps it into this FHIR system. And if they decide to move EMRs, they can go to the new EMR and go, get my patient data from my FHIR repository over here and reseed my new Athena system, right? And I pitched this to these two guys, and they both looked at me like, you're crazy. That's not what we do, and not right now, right? But it's just something. I've been a proponent of it for a long, long time, and I think it's becoming critical mass. But there's still a lot that people don't know, and in our space, not knowing what you don't know is the biggest problem. It costs the most money. It's the most overhead, and it's the most dangerous element of things. And for people like Jim and Marilee, when Ron says yes I can do that, they're like, okay, wait a minute. What don't we know, and what isn't he telling us, right?
Yeah,
you're pretty good at sharing. I do want to say that your idea eventually did turn into Gravity, that Reliance.
It did, yeah.
Or your payer, and I do want to support what Dan said and what Mike said. Definitely, I think we had some folks from Den on, although they may have had to drop off. But
there was Stevens there.
Yeah, Stevens here.
Oh, cool. The definitely for our client base, the activity we've seen with FHIR has been around the payer space, and even in talking with on the Care Quality Advisory Council that I'm a member of. We've talked a lot about the IHE messaging that's been around forever and nationwide data exchange versus FHIR. And I think it's pretty much a consensus with everyone that treatment, for data exchange that's already in place and working, nobody wants to change anything. It's working. Don't break it, which is a big reason why Stargate has an API for our modern engineers. And so it is really the new use cases. So when you look at all these new payer use cases under TEFCA, for example, the payers are they're skipping because they never supported HL7 in the first place.
Right.
Or CCDAs, most of them, they're just skipping right to FHIR. And then that need for those transformation services in the middle to bridge those gaps.
Well, as a matter of fact, what a great segue, and you didn't have actually any idea of the notes here. I want to move the thing on because we can spend an awful lot of time on this, but I'm also going to do that by giving a shameless plug to one of the things that we did create, and that is the FHIR to CCDA and CCDA to FHIR transformation services that we have built and are in the process of rolling out right now. So we do have that covered. Ron, give the specifics on it because we talk a lot about V3 internally, and just give the high level 411 of what that is because it's relevant to what we're talking about here.
Yeah, our primary use case today is working with a client that is trying to obtain Meaningful Use 3 certification for health IT technology. So we're really zeroing in on those requirements at the moment. But we've written a fairly substantial foundation that will allow us to add new document templates and piece together the individual section and data templates and associated FHIR resources and objects. And so far, it seems to be fairly resilient. Our particular guinea pig client is doing well with it. They're kind of our partner on the project, which is good. And it's running through the ASTP validator without issue. US CDI V3 is a requirement January 1st, 2026. We undertook this start of this project in January of 2025 with the team. The team went through a merger acquisition. They made some technology framework changes internally, so things slowed down a little bit on their side. And so they've opted now to quickly finish up the MU3 requirements for 2025, which is a blend of UCDI v1 and a few USCDI v2 data sections. And then we're going to be venturing into supporting UCDI v3 sections and most likely more document templates. And for what everyone knows about CCDAs, a document template is just a defined collection of various data sections and data elements. So it's a fairly high level hierarchy that allows us to maybe to manipulate that fairly quickly. And it's bidirectional and it has a validator.
Right.
So as an example, if you're attempting to build up a CCDA from a composition, a FHIR composition, while you're doing your development, you can be dropping that against the service and the service will spit back to you, yo, you're missing a null flavor over here, or you don't have this proper codification, or I was expecting a URI, you gave me an OID, fix it. That kind of stuff. And that's using the actual XSDs and schematrons for HL7v3. So we're using the source of truth to do that with. And we can do that on the inbound side too. So this is a big problem for HIEs. Everyone's getting hot dog food from all these EMR vendors and or variations. And so you can run that stuff through that validator and say, guys, you need to talk to your vendor or you need to fix this CCDA. It's not even close to being compliant, or we can manipulate it for you. And of course, reflect that manipulation and correction for them appropriately in your onboarding of that entity, right? And know that you got to do that, not deal with it downstream.
So sorry for the shameless plug there. Like I said, we try not to make this an advertisement for Zen's things, but it's something that's really relevant in the marketplace. I'm curious. Another quick survey for everybody. We've talked internally about the idea of making that a standalone service that does not necessarily require being on Zen's, part of Gemini or Stargate overall. It would just be a standalone service, an endpoint that you could hit to do that. Would that be valuable? Type yes or no in the chat and let me know whether that is something that you see that would be worthwhile. I like the hot dog food too. Okay, all right, good. So okay, good. We're gonna do some more looking at that. There's such a as you can tell from the marketplace, there's the CCDA and there's HL7 and then there's FHIR, and you tend to find folks that are in one camp or the other, and you can tell from this conversation that that's not a really good situation for folks for all the reasons that we've talked about here. So we're kind of looking at can we effectively enable everybody to speak each? And so that's what we're trying to figure out. And I think that there's some merit in that idea. All right. With that being the case, we've gone through you've sat through 43 minutes of this, you poor folks. But hopefully it has been worthwhile a little bit. Let's move on to topic two. There's a lot of stuff going on in the national networks. Oh, there you go. Mike has posted some stuff. I'll let Ron, you look at that for a second. National networks and TEFCA. And Marilee, actually, if you're still available, I'd like to throw this out to you a little bit here as well. I think everybody here knows that there are multiple use cases that the national networks are, at least by the specs, supposed to support. But it is treatment that will allow you to get data. And if you don't have a treatment use case, you have some problems in getting that data. Now, I have in my notes here to refer everybody to, if you have additional questions on this, you should be attending Marilee's office hours. And I'll let her put a plug in there as well, because she covers a lot of this stuff in detail, not necessarily from a pure technical standpoint like Ron does, but certainly from a practical standpoint from all of her sitting on these committees as well. I'll finally ask the question. Marilee, tell everybody what's going on with treatment use case and, as briefly as you can, the arguments that are going on right now as the definition and how people can use it.
Yeah, very timely. I literally just got off this month's Peer Quality Advisory Council meeting, and the interesting question that we're all trying to wrap our head around is that TEFCA decided to tighten down the definition of treatment when it looked at what Care Quality was doing, because Care Quality simply references HIPAA and says everyone must support HIPAA requirements. And some of the large health systems and large EMRs, I mean Epic, had concerns about some of the participants in the network and whether they were really meeting a treatment definition. And so that's really why TEFCA came up with a more narrow definition of what they call required treatment. And the reason they use the term required is you must respond, right? There's this reciprocity requirements in national network exchange. So that required means, so they actually in TEFCA have two kinds of treatment, required treatment and treatment. Well, like many of us have provided feedback on, if it's optional, no one's going to respond. So great that you did that, but probably no one's ever going to use it. So and now Care Quality is looking and saying, how can we align? The big issue that I'm going to be talking about tomorrow is that required treatment requires you to be the healthcare organization to be a covered entity. And you'd be amazed at the number of technically not a covered entity participants in nationwide and state HIE participation. I was talking with Mike, your boss, Eric, a couple days ago about some of the jails and mental health facilities, social service agencies that aren't covered entities but are participating in regional exchange, and many of them are also participating in Care Quality exchange. So there's a huge debate of the people that we're leaving by the side of the road if we do not fix this covered entity problem. And there's very strong feelings on both sides. And that's what I'll be talking about tomorrow.
So and there's a lot more to it, as you might imagine. Marilee and I've had a lot of internal conversations about some of those definitions. We won't have time and we won't cover it here. But if that affects you at all, or it affects the constituents that your organization deals with, which is probably the case for the vast majority of you, I strongly encourage you to join Marilee tomorrow for that discussion and get into it, because it's fascinating, and it's something that is moving very fast in the marketplace. There's a lot of decisions that are going to be made by the end of the year here, and they dramatically affect you. And if you can see it coming, you can do something about it. And getting slammed because you didn't see it coming is not any fun, as everybody knows. So it is.
Jim, I just want to call out Katrina's comment. Katrina says, we just discussed T treatment versus TR TMT treatment and TQM versus HEDIS on QM participant call. Why? So Katrina, could you?
Oh, and that probably came out a little interesting, but what I mean is, why did they make this so difficult? And why, like you just said, they're not going to respond if you allow them not to respond. And it's this super category of T-treat that, it's a should, and then treatment is the must for the covered entity. But why? And then HEDIS versus quality measures? Why? What's the difference? I mean, it's just getting way too confusing. And I think, we've talked on this call about IAS before, required, no one's responding. So, it's a mess right now. It's become way too complex, and people don't even understand what they're supposed to be responding for. And it's just, leading to problems with true interoperability. So,
well, and then you throw that requirement on there. Marilee, I think, mentioned the correctional department that we're in talks with. They've been on paper until this year. So they're struggling just to get on an EMR. And if they have an incarcerated person who comes in, it would be super helpful if they could see that the person had a substance use issue in Florida or whatever, but they're not going to be able to respond very easily if they can't even get on an EMR till this year. It's going to take them a while to get up and running that far. So for benefiting the patients, it's getting really complicated.
I I had an early phase discussion with one of our sales team folks with an incarceration entity, and it's very difficult for people to understand just that use case and how it works, right? If you've got the flu, they service you in the facility. If you need, an MRI or you need some kind of a heart intervention, they take you to the local hospital. And how do they get those records back into that solution at the facility and vice versa, right? How does the health system get the records coming out of the correctional facility? It's a mess. I mean,
And once they're released,
yeah,
you
yeah,
need the full suite of records. Yeah.
yeah. I did quite a bit of work with Maricopa County, the jail system when I was at the behavioral health EMR vendor, and it was all faxing. It's just all faxing.
Yeah.
It's really interesting to get to Katrina's why, whether you exactly meant it that way or not. I think that what we keep hearing is liability. And, even though there's states like, for example, Texas, that defines any licensed provider touching healthcare data as a covered entity. It doesn't matter that the federal might carve a concierge medical clinic out or an assisted living facility out or a free clinic out. It's Texas says you're a covered entity. And then I get told, well, that doesn't matter. It's state law, not federal. And I was like, but to your point, Katrina, why, when literally our agreement says state law does matter, we have to follow state laws. So it's very confusing. And that's why I actually think that the reason the carrier quality came back the board and we just heard today, they're putting our conversation and required treatment definition under carrier quality on hold, and they're pushing it back up to the federal level. And I think that's because they want some federal government pressure on some of the large health systems and vendors to get past this quote liability problem. And then we had the big announcement today that everyone will be talking about here over the next couple of days, as we're all still trying to sort through it. For those of you who haven't seen it yet, it just came out like in the last 2 hours, I think.
Oh, the pledge or whatever.
Well, yeah, the pledge and the CMS interoperability framework. And the interesting thing there is I did notice right quickly before this meeting that all the QHINs have pledged, right? So that's good. I think that tells me TEFCA is still in the mix there. But there's just a lot of unknowns. The other big positive thing, to your point, Katrina, about individual access services is they really put patient access front and center. So again, I'm hoping that extra federal pressure. I mean, that's the whole reason why TEFCA exists, really, is because nobody can get individual access
their own data, and they still can't.
Yeah.
Yeah. Well, in spite of all of that, and everybody's frustrations are real, and everything that's been talked about here is accurate. But I will look at the positive side of that as well. It has been, for as long as I've been in the business, that there really hasn't been these kind of serious discussions about those kind of problems and what are we going to do to fix it. And like I just said a couple of moments ago, we're going to see massive changes in what those regulations are and how we do these things, and learn more about what can be included, what must be excluded, and get a whole lot more definition of it here in the next 6 months. That's completely different than it's been for as long as I've been in the business. So I'm going to consider that positive progress, even though it is hair pulling to try to figure out what's going on today.
I'll give another huge positive. Athena Health just announced they're moving fully over to Commonwealth's new platform, and they are all in on individual access services. And that's a major EMR player coming to the table that's opting into individual access services. And I think that's just, we need that leadership. We need those positive examples. And that's just not even necessarily through TEFCA, but through Commonwealth and TEFCA combined.
It's the people that are on this call that are the people that are making, that are helping enable these kind of things to happen. Sorry, Ryan, I think you were going to say something.
Yeah, I mean, in that vein, Jim, that you were saying, and even to Marilee's point, all the movement that's going on, we actually have people that are listening to us too, right? In these technical work group meetings, I'm, in the work that we're doing, hands on keyboard, on the ground, I'm taking that stuff back to, the work groups and saying, guys, we're missing a technical problem here that needs to get a solution. And the first response is, Ron, would you be able to travel to meet with a consortium of people and sit in front of these people and let's help hash this out? Yes, we will. So we're actually getting people going, okay, that is an issue. Here's a use case. I lived in Arizona, I lived in Texas, I now live in Mississippi. I had healthcare in all 3 states, fairly substantial stuff in Texas. In Mississippi, I've had an annual physical and some general maintenance procedures, right? Just a annual thing. If I do an IAS application, the only address they're going to get is my address in Mississippi.
Right.
How are they going to find my records in South Texas? They're not, right? It's a huge gap. And we're getting the ear of people that are engaged with the RCE, and the RCE is saying, okay, bring those people to the table. Let's talk through it. So that is a huge benefit from a technical perspective. In the old frameworks, we really were barking up a tree a lot of times, right? Yeah. We would find a gap and we would take it to the framework management teams or the network and say, hey, this is a problem. Yeah, okay, we'll take a look at it. Not, let's get a bunch of people in a building around a table and let's start taking notes and modify the SOP, right? That's a big diff.
So I want to, this sounds corny, but I'm going to say it anyway. Pat yourselves on the back. I mean, seriously, because you showed up for this thing. And what we're trying to do here is not only disseminate information that we have, and, I will tout the team that we've put together here. Marilee and Ron both are sitting on a lot of committees and having influence on these things. I'm not kidding. It's real. And having Liz on this show in August, it's a big deal. We've got the ear of the right people. So it is important for you. Give us feedback. Give us the things that are there, the things that are causing you problems because the jail over here is still on faxing or on paper. It's important for this team to hear those things so that we can continue to bang the drum with regard to those. We need to affect them. It's a good thing.
And in the last minute, I just want to mention to everybody, in September at the Commonwealth Fall Summit, I will be speaking with Liz and the team about some subjects. So, we're going to bring some more of this to the forefront with IAS and other things, and TEFCA, data exchange, that kind of stuff. Okay.
So we had a whole nother series, another topic to talk about here about delegation of authority and the changes that have happened in that from on behalf of, for those of you who have seen the previous discussion that we had of that, there's a bunch of updates with regard to how that is playing out and how to get approved for it and how that can really affect a lot of health tech vendors overall. So we will save that. We'll try to put that together and see if we can wedge that in next month's as well. So we hope that you'll join back with us. It's 58 minutes after the hour. I'll open the floor here. Anybody got any other suggestions or thoughts for us to do before we adjourn? Because we adjourn on time for everybody. Any other thoughts? Is it worth? Is it worth? Is it worthwhile?
I'm batting 1,000, Jim.
God.
Batting 1,000. You got one more show to trip me up. One more to trip me up.
Okay. We're going to challenge. I'm challenging Liz to make sure that she brings the tough stuff, and we're going to stump the chump next month. Be here. It'll be great. All right, everybody. We'll return.
Thank you.
1 minute.
Bye, guys.
For coming.
Thank you for joining. We'll see you later. Bye-bye.
Take care.
Thank
Bye
you.
now.
See you.